Good afternoon, everyone. My name is Tia Teriak, and welcome to What's Up, Doc. This is Concord Hospital Trust's monthly lecture program brought to you as a community service, and we hope you enjoy our program today. Traditionally, we do devote October to breast cancer awareness, and I'm happy that we're continuing that tradition today, as you can tell by some pink that you see here. We'd like to thank and recognize the Walker Lecture Series for their generous sponsorship of What's Up, Doc. The Walker Lecture Series offers lectures on history, literature, art, science, as well as dramatic, literary, and musical performances. All events are free to the public and are held at the Concord City Auditorium. We encourage you to check out the walkerlecture.org website to see their schedule of upcoming programs. Today we are delighted to welcome Dr. Jeanna Walsh from New Hampshire Oncology and Hematology to us to be our featured speaker. Again, we are devoted to breast cancer awareness and new treatment options and new information. To introduce Dr. Walsh, I'd like to introduce Cassie DeLude from the Breast Care Center.
Hi, everyone. As she said, I'm Cassie DeLude. I started with the Breast Care Center at the end of August, and I'd like to introduce Dr. Walsh to you all today. She's going to be our speaker. She attended medical school at State University of New York, Upstate Medical Center in Syracuse, and she completed her residency in internal medicine and fellowship in hematology and oncology at Strong Memorial Hospital in Rochester, New York. She is a member of the American Society of Clinical Oncology. She is also a member and actually an incoming board member of the Northern New England Clinical Oncology Society. She's the medical director of the Dana-Farber New Hampshire Oncology Site in Londonderry, and she's been with New Hampshire Oncology for about 15 years now, working out of the Londonderry and Concord offices. She will be speaking today about hopeful advances in metastatic breast cancer. And I'll turn it over to Dr. Walsh.
Thank you both. I've been a little bit plagued this week with allergies, so if I have to stop and take a few sips of water, forgive me. When I was asked to give this talk, I thought through what would be an area of breast cancer where we've seen some real movement recently. I would say when I was in medical school and early days of training, the landscape of treatment and outlooks for metastatic breast cancer were not nearly as positive as they are today, and we know a lot more about the biology of breast cancer, including metastatic breast cancer, than we knew then, and that allows us to take advantage of that biology and prolong and extend patients' lives while helping them to maintain a good quality of life. There's been a lot of change over the years. Right when I was in medical school, that was the end of the time when we thought perhaps stem cell transplants would lead to long-term survival for breast cancer patients with high-risk disease. So, over the years, many different things have been tested and tried, and I will talk a little bit at the end about clinical trials and just give you a little bit of background of how the clinical trial process works and leads us to better treatments. So I think it's always important to kind of define what we're talking about when we're talking about metastatic breast cancer. And when I first meet patients, I try to talk with them about what exactly this means to them. So let me just see. First, I'll just go over what's the scope, how many women are diagnosed with metastatic breast cancer yearly. We have about 300,000 new cases yearly. 6% that's breast cancer alone. 6% of patients will present with what we call de novo metastatic disease. In other words, they've not had a diagnosis of breast cancer previously, and they either are found to have metastatic disease based on a symptom that they presented with, pain, shortness of breath, and then that leads us to determine that they have an underlying breast cancer, or perhaps they have a mammogram which shows a breast cancer and we decide we need to look further and make sure they don't have metastatic disease, and we identify it at that point. That, again, is what we would call de novo disease. So when we're looking at staging of breast cancer, metastatic breast cancer is called stage 4, and that's because it has spread beyond the local regional area of disease. So the reason we do mammograms is in order to identify early stage breast cancer, and then we do surgery, and that gives us information about the size of the cancer, whether lymph nodes are involved, and the biology of the cancer, and we make treatment decisions based on that. When we identify that the cancer has spread beyond the breast and the lymph nodes, that's when we're dealing with metastatic breast cancer. And it can travel anywhere, but the most common sites of disease are the bone, liver and lung, sometimes the brain. I recently saw a patient who on a screening colonoscopy was found to have breast cancer in a colon polyp. That's not common, but that's a situation, as I was talking about, where we're finding de novo metastatic cancer, and we have to work through the process of treating that patient and sorting through the best treatment for her. So going on to talk about biology, and I would say over the course of my career, this is probably the most important thing that's changed in how we treat breast cancer. 20 to 25 years ago, any woman who presented with a 1 to 2 centimeter or bigger cancer, in particular if their lymph nodes were positive, but even without lymph node positivity, we would give them chemotherapy. And over the years, what we've learned is that we're probably over-treating a lot of women because of the different biologies of breast cancer. So these are sort of the big buckets of biology for breast cancer. So the most common and most prevalent breast cancer type is hormone receptor positive. These are estrogen sensitive and progesterone sensitive, focusing more on the estrogen. That's really what we can manipulate. Estrogen receptor cancers. So these cancers are driven or stimulated by the presence of estrogen in pre and postmenopausal women. They tend to be slower growing, more indolent, as we like to say, and have a better prognosis overall than the other two subtypes. And what I tell patients sometimes is, with an early hormone receptor positive breast cancer, I could throw as much chemotherapy as I can think of at their cancer, and it probably won't do a lot of good. Chemotherapy relies on a cancer dividing pretty rapidly. These are slowly dividing cells, so we have to take sort of a long marathon approach to them. So HER2 positive breast cancers, HER2 is a protein that can be overexpressed on breast cancer cells. And that protein, when it's overexpressed, sends a signal to the cells to proliferate and overproliferate. Again, 20 years ago, very different story with HER2 positive. We didn't have a lot of tools to deal with it, and that changed dramatically in about 2005 when a paper was presented at our big conference showing that the drug Herceptin, when given to patients with early stage breast cancer after surgery, along with chemotherapy, dramatically improved the survival of women with HER2 positive breast cancer. We knew that Herceptin worked in metastatic disease, but this proved that it was important in what we call the adjuvant setting. And now I probably need at least 2 hands to count all of the agents that we can use and cycle through in patients with HER2 positive metastatic breast cancer. So that's a huge movement in that realm. So then we have triple negative breast cancer, which is arguably the most aggressive breast cancer that we see, the most likely to metastasize, and the one that we have the fewest tools to combat. Because it's not hormone receptor positive, we don't have the hormonal tools, and because it's not HER2 positive, we don't have the HER2 targeted tools. So we really are left with chemotherapy alone, but More recently, we have added immunotherapy to our armamentarium for triple-negative breast cancers, both in the metastatic setting and very exciting in the pre-surgical setting. We can see that women who receive immunotherapy with chemotherapy in a triple-negative breast cancer can have a very good response before surgery. So definitely reason for hope in that realm. So I always feel like these things are better to be interactive. I'm happy to take questions during my talk, but also after. So just don't be afraid to chime in.
Well, I'll start.
Okay.
Immunotherapy at this point just for triple negative?
Yes. So basically, we're only utilizing that in triple negative. That's where the data is right now. Other than, we can go a little bit later into this idea of next generation sequencing, where most people who have metastatic cancer writ large are getting extensive testing of their tumor for mutations and other findings that might contribute to our treatment options. All right, so we went over the basic statistics. So when I'm talking to a patient with a new diagnosis of metastatic breast cancer, a lot of times their first question is, what's my prognosis? How long can I live with this? And that's a hard question to answer because if we look at all comers, that looks terrible, right? 2 years. 5-year survival, 30%, and median survival, meaning, we'll see half the patients live longer and half the patients not live that long, is 2 years. But what we have to remember is that's all comers. So that's all of those different subtypes that I talked about, and we know that each of those subtypes is going to have a different outcome. So I try to put it into perspective and communicate that survival is really along a spectrum, and we can't tell any individual patient what it's going to look like for them until we start treating them and see how they respond. But then if we break it down into the different subtypes, that triple negative type has a lower, unfortunately, and expectedly survival of 11% and a median survival of 33 months, which I guess belies my 2 years a little bit there. But and then ER positive, estrogen receptor positive, those are the patients who we anticipate are going to do the best. We're going to be able to treat them with minimally toxic treatment. They're likely to respond to each subsequent treatment fairly for a good period of time, and we anticipate, median survival of 57 months. And HER2 positive breast cancer, again, because we have all these extensive tools at our disposal, is going to have a 30 to 45% 5-year overall survival and a longer median survival as well when we look at those statistics. And so part of the philosophy and the strategy of working with patients with metastatic cancer in general, and in particular breast cancer, is we want to start with the least toxic therapy that's likely to be the most effective. There's a tendency to think that, we should just go with chemotherapy because that's the most aggressive, and that's another question people ask me: are you being as aggressive as you can be? And we don't think of it that way. We really think more about, are we choosing the most effective treatment at this point in time in this disease course that we can, with the highest likelihood of achieving a response. So kind of going through how it might look for a woman or a man, of course men can get breast cancer, to be diagnosed with metastatic breast cancer. We talked a little bit about de novo disease, but an important component of detecting metastatic breast cancer is the monitoring and surveillance that we as medical oncologists do, that our radiation oncology colleagues and our surgical colleagues do. We tend to see these patients at least yearly and coordinate with our colleagues to make sure that they're seen 2 to 3 times a year. And what we're doing at those visits is we're asking them about symptoms. We're, kind of making sure they're not having any findings that are suspicious to us. We're not necessarily doing routine blood work or routine scans other than breast imaging, because that hasn't been shown to be helpful, but we're very sensitized to symptoms and, looking into symptoms. So I just, saw a patient today who had finished up chemotherapy within the past few months, and I was doing some labs just because I wanted to make sure she was recovering from chemo. And one of her liver functions was a little bit off when I saw her a few weeks ago. And she's at high risk. So I said, well, let's just do a bone scan to make sure that that funny number, which is sort of a liver and a bone thing, is not telling us something. We did a bone scan, it was negative. She's relieved, I'm relieved, and, that's the kind of way that we might detect a recurrence in somebody that we're following. So the next piece, when something like a recurrence is suspected and detected, it's very important for us to do a biopsy of the site of metastatic disease. Breast cancer can change. We can have somebody who had a HER2 negative cancer or HER2 positive cancer, and when we biopsy their site of metastatic disease, that might be different. Same with the estrogen receptor. I've seen patients who are ER positive. Nick knows one of my patients very well who started off her breast cancer journey as ER positive, and now we're treating as ER negative with immunotherapy, just coincidentally. So it's really critical to get that information at the time of recurrence to choose therapy effectively. I talked about that philosophy of treatment, the least toxic, most effective. And then once we diagnose a patient with metastatic breast cancer and start them on treatment, there are different ways that we follow it. No single follow-up exam or study determines progression. We we put everything together and synthesize it. So we have blood tumor markers that are sometimes helpful in following metastatic breast cancer. So these are blood tests that can be very elevated or moderately elevated because of the breast cancer, and as the treatment is effective, we'll see those come down, either trend down or come down to normal. And when they start to go back up, that can be a clue that something's going on. Symptoms. Once we start treatment, we can often see significant improvement in symptom burden. Physical exam is important. If there's something on physical exam, lymph nodes, skin nodules, that we can watch to see that they're regressing and improving and responding to treatment. And of course, imaging. We generally image either with CT scans or PET scans every 3 to 6 months, depending on the patient and the underlying, sort of pace of the cancer. So genetics is a big topic in breast cancer in particular, and that's changed a lot since I've been in practice. It used to be that we would want patients with a strong family history to get BRCA testing. Has everybody heard of BRCA testing? Angelina Jolie has a BRCA mutation. And those are the most worrisome, I guess I would say, mutations in terms of overall lifetime risk of developing breast and ovarian cancer. The numbers are very high, like up to 80% of patients with a BRCA mutation will get breast cancer. So what's changed over the years is who we recommend gets genetic testing. It's broadened as time has gone by, because we know more about different mutations and different inherited syndromes than we used to, and plus it's become more cost effective to do broader testing. So a lot of times these panels that are done through genetic testing include 30, 40, even more genes, which of course makes the job of genetic counselors more and more complex, and we really rely on genetic counselors to help us guide patients through the process of whether they should get tested, and interpret the testing once it's back. And interpreting that testing includes, how they share information with family members, whether they need preventive surgery, removal of the ovaries, removal of the breasts even, and what kind of surveillance they need for either breast cancer and other cancers that they may be at risk of. We do tailor treatment of metastatic breast cancer to some degree with our genetic testing, especially BRCA1 and BRCA2, and I have a case coming up where we'll talk about that. So then, these are conversations that take a little time too, because I think we've gotten a little bit muddied in the water with what we call next generation sequencing, which is a very distinct type of testing that we do to guide therapy as opposed to genetics. So whereas when we do genetic testing at the breast care center, they do that through the Dana-Farber program, we're looking to see if you were born with a mutation, if you inherited a mutation from one or both of your parents that's going to increase your risk of cancer. What next generation sequencing is that's the tool that we use to look at the cancer itself and whether that cancer has mutations that are acquired and led to the cancer being able to grow. So those are called somatic mutations as opposed to germline mutations that you're born with. We use a number of different test platforms for this. I think most of us here are pretty comfortable with Foundation testing. Guardant is another one, Tempus is another one. Different hospitals down in Boston have their own sort of in-house tests that they perform. But what they all produce is a list of genes and whether there are mutations in that genes, and ideally when we look at those reports, it also gives us information about what treatments might be indicated for those patients. We can do that on the tissue that a patient's had with either surgery or a biopsy, but we can also fortunately do it on circulating tumor DNA that can be removed from the blood for testing. And
Does that tissue have to be grown, or just from the path specimen?
Nope, just from the pathology, yeah. And we actually have a clinical trial right now, which is super interesting, where we're asking both patients, but also volunteers without a diagnosis of cancer to give us circulating tumor DNA to try to figure out how we're going to use this in the future to follow cancer and probably also to detect and screen for cancer. Yeah.
Let's say a woman doesn't have breast cancer in her family or anything, but is just concerned that she might develop it. Would you do a testing like that, DNA testing on her?
Probably not. So I would recommend that woman get routine screening mammograms, which is still the best way to detect breast cancer. This would not be a screening test that we would, so.
Those that have.
In the future, and I'm not sure, probably decades in the future, that might be, we might all go and give a drop of blood and.
I would want to know.
Right. That's the other piece with genetic testing is, you have to be ready for what results might come through. All right. So now we'll go on to moving through some treatment paradigms. So starting with estrogen receptor positive metastatic breast cancer. As I mentioned, what we're doing here is we're trying to manipulate that estrogen piece. So we're trying to take away this hormone that is stimulating the growth of the cancer cells. So that can include ovarian suppression in somebody who's premenopausal. We can either remove the ovaries or we can give a shot once a month to once every 3 months that stops the production of estrogen. In addition to that, we also have to give a medication that either blocks the ability of estrogen to get to a cancer cell or simply eliminates the production of estrogen. Even in postmenopausal women, there's estrogen production in the adrenal glands and in fat cells. So we still have to block that production. So then I'll skip down to bone strengtheners. Anytime a patient has bony metastases, which is pretty common in estrogen receptor positive disease, we want to protect them in a couple of ways. One is protect them from pathologic fractures. So the cancer growing in the bones is weakening the bones, and so increased risk for, you step off a stair and boom, you've got a hip fracture or a femur fracture. So these drugs called bisphosphonates, which, in oral form are, are things that you would take once a week or once a month. We give them IV, so they're stronger. And those strengthen the bones, but the other thing we think they do is they change sort of the milieu of the bones and makes it harder for cancer cells to thrive within that environment. We generally give that either, once a month for a year and then every 2 to 3 months thereafter. Radiation can play an important role in symptomatic disease. So if somebody has a bony metastasis that's causing pain, our radiation colleagues can radiate that, and that can provide very quick and powerful relief to that symptom. I've had patients with really significant skin involvement who've benefited from radiation, patients with open cancers that we need a quick response, we can use radiation. So going back up, CK4/6 inhibitors. So this is an adjunct that we use with hormonal therapy in metastatic disease. The drugs are called palbociclib or Ibrance. There's a couple of others, abemaciclib or ribociclib. And they sort of just, the way I think about it is by reducing cell cycle activation and inhibiting cell proliferation, they augment the effect of the ovarian suppression and estrogen blockade. And with palbociclib, patients who were receiving their first round of anti-estrogen therapy had a doubling of their progression-free survival. So instead of having to switch therapies at the 1-year point, they went to 2 years before they needed to change to a different therapy. PIK3CA mutated cancers. This is a specific mutation which we can see in multiple cancers, but it's most critical in breast cancers. Again, targeted with a drug called alpelisib, which is an oral drug that we use in combination with hormonal therapy. So those have changed the landscape quite a bit. When we don't need any kind of mutation for the CK4/6 inhibitors, but we do need to find this PIK3CA mutation in order to use alpelisib. So we cycle through hormonal therapies for ER-positive metastatic breast cancer. We'll start with, two pills, let's say letrozole and Ibrance. At time of progression, it's an art, not a science. We kind of introduce different treatments. We can change the pill that we're using. We can use an injectable estrogen blocker. We can add different helper drugs. So I would say on average, somebody with ER-positive breast cancer will probably cycle through 6 different hormonal programs before we have to think about switching over to chemotherapy at this point. And when we do exhaust all of those, we then start talking to our ER-positive patients about chemotherapy. Usually starting with this, we usually use one drug at a time. We don't use combination chemotherapy in this setting because it's more toxic than we need, and we can generally cycle through several chemotherapy options as well. Some of them one chemotherapy option is oral, which makes it a lot easier, but for the most part, we're still in the IV chemotherapy realm when we're treating breast cancer. So to illustrate that, so I have a 44-year-old woman. She was diagnosed 6 years ago with an ER-positive localized breast cancer. She was found to have a BRCA2 mutation, so she underwent bilateral mastectomy as well as having her ovaries removed at the time. She took hormone blocking therapy for a brief period of time, but then several years later, last year, she came in, she was exhausted, she was very anemic, she had back pain, and she was found to have pathologic fractures. So we went ahead and did the biopsy that we needed to do to confirm her cancer was the same profile as her original cancer. She underwent radiation successfully to her painful bone lesions, along with, oral pain medications, and we started her on. So she's already, even though she's young enough to be premenopausal, she's had her ovaries removed, so she's menopausal. We were able to start her on letrozole, an aromatase inhibitor, and the Ibrance that I just mentioned. So she responded as we would expect for quite a good period of time, 16 months. At that point, and I took her off the letrozole and switched her to an injectable hormone medication called Faslodex and continued her on the Ibrance. Pretty soon after that, she progressed, and because of her BRCA2 mutation, I was able to start her on a PARP inhibitor, and she seems to be responding to that. So PARP inhibitors. So these are poly-ADP ribose polymerase enzymes, is what PARP is, and these function in DNA transcription and repair. So basically in making, cell division work effectively and regulating the cell cycle. And when patients have mutations in one of these, they're deficient in PARP, and that allows the cells to just proliferate without control. So when we go in and correct that with PARP inhibitors, that induces damage in the cells and leads to what we call apoptosis or cell death. And they're very well tolerated. We use them in ovarian cancer a lot as a maintenance. Low blood counts are the most common thing I see with them, and we just have to adjust the doses. And some GI issues. So these are very important medications in BRCA positive patients, but also in ovarian cancer, even in non-BRCA patients. So next case, or next type, HER2 positive. So basically, HER2 positive patients can be either ER positive or ER negative. So all of the same sort of principles apply if they're ER positive to what we do. But we can then, in addition to estrogen therapy, blocking therapy, we can do HER2 targeted therapy. If they're ER negative, we will do a combination of chemotherapy, again, usually a single agent with HER2 targeted therapy. And the combinations of chemotherapy and HER2 targeted therapy are almost endless. We can sometimes go back to something we used before and still get a response. So there's a lot of options for HER2 positive patients. Same thing with the bone strengthening agents, radiation, we use them in the same exact way. And that's just a list of the most common HER2 targeted therapies that are available today: trastuzumab, pertuzumab, TDM1, and HER2, which is what we call a drug antibody conjugate. I have a whole slide about that one, or about that idea. There's some oral HER2 targeted therapies. And again, we can even use those in combination with IV HER2 targeted therapies. So there's a seemingly unlimited supply of those. So case for HER2 positive.
Those are all considered forms of immunotherapy?
Well, yes, antibody therapy. So immunotherapy, and I can,
I got it.
yeah.
Polypolymerase, that would be considered.
Targeted, yeah, more molecular. Yeah, so I kind of break them into antibody therapy, molecular therapy, and immunotherapy. So our case for HER2 positives was a 68-year-old woman who had had breast cancer many years, very remote history of breast cancer, 15 years. And it was at the time, and this is a good example of the biopsy, importance of the biopsy, she was ER positive, PR positive, and HER2 negative. She went through the usual rounds of treatment and was, discharged from care appropriately. And in 2021, she developed shortness of breath and was found to have fluid around the lung, a pleural effusion. She had that removed and had a procedure to prevent that from recurring. And the biopsy, the cells showed breast cancer, which were surprisingly ER negative and HER2 positive. So if we had just assumed that this was her breast cancer and that it was the same as her last cancer, we might have gone down the wrong path. She had, in her staging studies, her lungs were involved, her liver, her bones, her lymph nodes, so she had a fairly high volume of disease. I started her on combination chemotherapy with 2 HER2-targeted IV therapies, trastuzumab, pertuzumab, and she didn't really respond very well to that. She progressed pretty quickly. So we started her on TDM1, which is one of these antibody chemo conjugates, and she's had a great response to that and continues on it with good tolerance. She gets a drug called Xgeva for her bone metastases, and I know what I'll do next for her if I need to, and when I need to change therapies is we'll change her to a different antibody conjugate called Enhertu. Yeah.
So because of the differences, is that considered a recurrence?
Yeah, so that's a tricky one. Is it a de novo, different cancer? There was no evidence that she had another breast cancer. So sometimes we don't ever know the answer to that question, but we treat the cancer that's in front of us. So yeah, exactly. Good question. So antibody drug conjugates. So these, we take advantage of the HER2 targeting that a drug like pertuzumab or trastuzumab has, and by adding a potent chemotherapy agent to that molecule, it actually delivers the chemotherapy and the HER2 targeting agent directly into the cell, and that makes the chemotherapy less toxic. So if we're just flooding the blood with chemo and it's just sort of having to figure out where to go on its own, it's going to go everywhere. This way we're not having as much chemotherapy in the bloodstream harming normal tissues. And we get, again, the benefits of both therapies with less toxicity. And those are the examples we've already mentioned. And I think it's like my only picture. So this is Enhertu. Doesn't really matter, it could be TDM1. So you can see that the antibody, the little green thing with the red dot, which is the chemotherapy, that gloms on to the HER2 receptor on the cell, and that the cell then kind of grabs onto it and brings it into the cytoplasm. The drug is delivered to the nucleus and does its thing with the DNA and killing the cell. And when the cell dies, some additional drug is actually released, which can then go back into other cells and continue with its process. So you do get some drug in the bloodstream, but not as much as you would if you were just simply giving chemotherapy the standard way. So I thought that was a nice illustration of that particular concept. So triple negative, we talked a little bit that we really have just chemotherapy, or at least until recently, had only chemotherapy. And then more recently, we've had targeted therapy with immunotherapy, sometimes based on our next generation sequencing. I'll talk a little bit, I have a slide about sacituzumab, which is a relatively new drug which has specific efficacy in just triple negative breast cancer, and the same concepts of bone strengthening and radiation as needed. So our triple negative case is a 52-year-old woman. She had a lumpectomy, chemotherapy, and radiation several years ago for a triple negative cancer. She developed recurrent disease in 2021, and we started her on oral chemo with Xeloda. When she progressed through that, she got Taxol and then a drug called eribulin. And this is where sacituzumab comes in, another drug antibody conjugate, and she's had relatively stable disease and improvement of her symptoms with that. So this is, again, another antibody drug conjugate. Its specificity is for a molecule called TROP2, which is overexpressed on our triple negative breast cancer cells. And the trial that was that established this was done in patients what we describe as heavily pretreated patients. And that's important in the sense that patients who have gone through multiple cycles of chemotherapy are generally considered fairly refractory to chemo at some point. And when they respond to something like sacituzumab, that's very encouraging. So you can see that the median progression-free survival for patients on the sacituzumab was almost 6 months compared to less than 2 months with standard chemo, and the median survival was almost doubled. So that, not great. I mean, we want to see better numbers than that, but that was significant for a new agent in triple negative breast cancer. So I just thought it was important to talk a little bit about how clinical trials work, because I think it's a little bit of a black box for a lot of people. So in any medical specialty, clinical trials are important, but I almost feel like in oncology, they definitely are the only way that we make progress. So, and they determine which drugs the FDA is going to allow us to use, and we can really only use FDA-approved drugs in our patients. That's a very important part of what I do every day, is I'm making sure that I'm choosing appropriate, effective drugs. We can't just kind of go to our chemo cabinet and say, well, maybe this will work. So when we look at the types of trials, there's phase 1, phase 2, and phase 3 trials. In order to obtain FDA approval, almost always, you need to have a phase 3 trial that has supported and shown a drug to be more effective than the standard of care. So most oncology trials in the phase 3 setting are comparing what we are doing now, the standard of care, to something new. And that can be the standard of care plus something, or something different and distinct from the standard of care. And trials are available in any number of settings. So places like Dana-Farber or Memorial Sloan Kettering, of course, have many, many trials, but a lot of those trials are also available in the community. And we have a robust clinical trial program at New Hampshire Oncology, so that patients, not just in big cities and who have access to those places, can have access to trials. And so, these take a long time, as you can imagine. It takes years to even accrue the right number of patients to a trial, and then for that data to mature to a point where we have published papers and abstracts that support a change in what we do. Prior to a drug being able to be studied on a phase 3 trial, we look at them in phase 1 and phase 2. And those are more fact-finding. Phase 1, we're basically giving a single drug to everybody, trying to see what dosing and efficacy might be the case, is going to work. And phase 2 trials are a little more sophisticated, a little more advanced than that. Sometimes they're comparison trials, sometimes they're just a single arm trial. But those are the trials that we need to support going to a phase 3 trial. So I think the message I want to convey about clinical trials is that they're critically important in oncology, and nobody should ever feel, I think, that they're likely to receive a placebo or that there's not incredibly strong oversight going on for patients who are on clinical trials. So that was what I had to share, and love to take questions. If there are other questions. Yeah.
Well, this is a financial question.
Yeah.
On the patients that go on clinical trials,
Mm-hmm.
are they charged the same as if they were receiving the regular drug?
Yeah, so that's a great question, and the answer, as it so often is it depends. So there are clinical trials that are run by institutions, academic institutions like Dana-Farber, or we have clinical trials through a organization called Alliance. And then there are clinical trials that are run by the pharmaceutical companies. Generally, insurance companies, I think, have agreed that for clinical trials they cover the standard costs, and sometimes the drug is provided by the pharmaceutical company. But generally, there's no additional out-of-pocket cost for a patient to be on a clinical trial. And that's, I think, an important component. And some people would argue that when you're on a clinical trial, you actually have more eyes on you. You have a clinical trial nurse, clinical trial assistant, there are, and there's a lot of oversight and a lot of attention, so.
So I have a question. I was listening to a talk by a medical student this morning about a certain type of rectal cancer.
Mm-hmm.
A study out of the New England Journal in the middle of summer, where this patient was treated with this programmed death thing, -1. And the interesting thing about the paper was these were fairly advanced rectal cancers.
Mm-hmm.
All 12 patients got this, and all 12 had the cancer disappear.
This was the Yale study, right? Yeah, it got a lot of attention over the summer.
So is that something on the horizon, or is that too soon to tell, or is anybody thinking about this maybe at breast?
Yeah, so that was immunotherapy. So yeah, so that I'll go and so immunotherapy. So you see the ads for Keytruda, Opdivo, and that's immunotherapy. And the idea behind immunotherapy is this: cancer cells are incredibly smart, and they effectively turn off some patients' immune systems and the immune system's ability to fight them. Because every day throughout our bodies, our immune system is tracking down cancer cells and getting rid of them. And if cancer is able to turn that off, you can imagine that helps the cancer grow. So what immunotherapy does, I think of it as a trainer. It's like a personal trainer for the immune system. It goes in and it turns the immune system back on. Okay, and that's a very simple way of explaining it, but I think it makes sense. And then the second piece of that is there are some immune systems that are very trainable, just like there are some people and dogs that are very trainable, and there are some immune systems that are perhaps not as trainable. So I've had patients who have received 2 doses of immunotherapy, and I had to stop it because they got toxicity of some sort, and they're still cancer-free. This is metastatic disease, and it's not come back. And then, we'll sometimes treat for 2 years with immunotherapy and then take a pause and still, see that that's effective. So it's not so much that the drug itself is doing anything to the cancer cell, it's the drug is teaching the immune system to do its job again. So we are using that immunotherapy in locally advanced breast cancer, so stage 2 and stage 3. Either it's a large tumor or a tumor with lymph nodes. And when we add immunotherapy to chemotherapy before surgery and breast cancer, we're seeing increased numbers of pathologic complete responses. So in other words, when the surgeon goes in and does a mastectomy or a lumpectomy, there's no cancer cells left in more patients. And that's a good indication that in addition to the cancer in the breast and lymph nodes, any cancer cells that were in the rest of the body have also been eliminated, and we anticipate that patient's going to have a better prognosis. So I do think that that trial is probably not going to change what we do right now, but it's going to lead to more trials to determine if we should be doing that.
In the breast group that might get this, is it the triple negatives? Is it
Yeah, it's triple negative. Sorry, I should have said that. Yeah. No. Yeah, but that's again, clinical trials moving, looking at that. So.
Only for folks with documented metastatic disease at this point.
For the triple negative? Nope, that's the.
I mean, if you're triple negative and you get immunotherapy, does that mean you have metastatic disease?
No, stage 2, clinical stage 2 and stage 3 can get this regimen now. Yeah, so that's been a big change, like literally in the last 18 months for us. And it's a rigorous regimen in terms of they're in the office a lot. They have a lot of,
and they're
but.
Not done with their therapy and then getting a mastectomy because there's nothing there.
Nope, surgery is still the standard of care, right? Yeah, so.
Finding cancer in the specimens when they do that.
Oh, well, some, but not all. And then the other piece that we have with triple negative is after all that, if there is residual disease, then we might give them additional adjuvant, Xylota. So, yeah, there's they get exposed to a lot of drugs if they're for triple negative for sure. But yeah, immunotherapy is arguably the most exciting thing that's happened in solid tumor oncology recently. So, all right. Thank you guys for your attention. We appreciate it.
Yeah, no, thank you.